Good morning, PS, Ms. Lai Wei Lin, and distinguished guests and participants. What has a psychologist slash police, biologist slash engineer, and doctor slash lawyer have in common? Prof. David Chan, Prof. Michelle Williams, and Prof. Kenji Saito are our distinguished keynote speakers for this year's Public Health and Occupational Medicine Conference. Their careers and experiences exemplify the spirit of our conference as they each pushed the frontiers of their respective domains. It is my honor now to introduce our conference opening keynote speaker, Professor David Chan. I first heard Professor David Chan speak some 8 to 10 years ago in a local healthcare conference. He said something that resonated deeply with me. He suggested that for us to build healthier societies, for our healthcare system to move forward, we would have to marry medical science and the arts and social sciences. Professor David Chan is a professor of psychology and the director of the Behavioural Sciences Initiative at the Singapore Management University. His research has been published in top psychology, management, and methods journals, and he has been cited 15,000 times. In 2020, he was named in the top 1% worldwide across all scientific disciplines in terms of research impact by a Stanford study. On top of that, he has won many international awards with names that I cannot even pronounce. He sits on several national level boards, committees, and councils, and is a consultant to numerous other public, private, and people sector organizations. Together with Nobel laureate in economics, Professor Daniel Kahneman of the Thinking Fast and Slow fame, and Professor Ed Diener, Professor Chan served on an international committee that submitted to the United Nations a report on the measures of national well-being across countries. That report was subsequently incorporated in United Nations Development Report. I can easily go on for the next several minutes of about Prof. Chan's accolades, but I'm sure that by now you must be eager to hear him speak. So without further ado, let us please welcome Professor David Chan to deliver his opening keynote speech. Professor David, please.
This one, okay, how this? Okay, hi, good morning everyone. I'm David and I'm very happy to be here this morning with so many familiar faces. Good morning especially to PS Lai, whom I've known for more than a decade now, I think. We were on the same course, same course long ago, and we were in the same plane, and we had very interesting experiences, if PS you remember. Yeah, she laughed. You can ask her later. And of course, to our distinguished guests, many of you whom I've met as Hui Yang said at previous conferences. By the way, sit back and relax. I don't have a script, and I speak very informal at keynotes. And I'm on sabbatical leave now. I don't know why I'm here. So I want to thank the culprits, which are the organizing committee chairman and the scientific committee chairman who just spoke, who got me here. I'll be going back to Japan soon. I came back from Japan to do this, as well as other things, right? What I want to do is to, of course, share with you about social behavioral sciences. That was a suggestion given to me to speak with you. I think we're still okay on time. I don't have to spend a long time on this because I know we have quite a diverse audience. Although you are a very well-informed audience and would have read up on social behavioral sciences stuff and how it relates to public health, I think still it is going to be quite diverse, right? So by the law of normal distribution, I'm going to focus on the plus minus 1 SD. So if you find my talk too easy, please forgive me. If you find my talk too difficult, it is okay, don't worry. What I've done is I've agreed to be on the panel later after the break together with the plenary speakers. So I would suggest that you jot down some notes, some questions that you might have, and then we can discuss, right? But don't spend the whole panel talking about a keynote because we have four panelists later to discuss, okay? I want to thank, of course, the nice introduction given to me. The fear of introduction is we always try to give you short bios and not long ones, because one thing you learn in behavioral sciences is when you raise expectations too high, that is the worst thing that can happen to the person that you praised. Okay, so lower your expectation a little bit of who you are speaking, who you are hearing right now. Now, what I want to do, of course, I was given the theme of the conference is Frontiers in Health, and I was told that please talk about social behavioral sciences and, of course, how it relates to public health. I think you mentioned I was a police officer. Yes, I was a police officer for 9 years before being an academic. There are three groups of people that I find it a little bit difficult to decline keynote speeches invitations. Right, I try to decline when I can. As you get older, you tend to want to do less things. Oh, I can't say that, it's active aging. Right. But so there are three groups, as I said, that I find it a little bit more difficult to reject, or rather maybe more likely to accept. That's a more humble way of putting it. And that is, the first group is people in education, right? Of course, I'm a professor and I'm in education, but really education because I think it molds the lives of our people, right? And therefore the nation. The second group are police and the home team in general, because they don't mold lives, but they protect lives. And the third group is people like yourself, which are people in health, because you don't really mold lives. You protect lives not in the physical sense, but you save lives. Right? But I think we are in a stage where we realize that saving lives is not just about treatment efficacy. Of course, that is very important, right? When you take the Hippocratic Oath, and not just doctors, but the whole ecosystem of professionals. But you realize now that prevention is extremely important. Right, and I think I don't need to be the one to tell us that the treatment efficacy of any treatment method, right, is a function of many things, one of which the baseline health that a person comes with, right? If you don't have good health, your method can be wonderful, and your method can be wonderful and standard with the same doctor, but there's going to be a variation of survival rates and health recovery of the people because they come with different health baselines. Now, once you realize that, please recognize that Healthier SG and all, when we say we shift the focus to prevention health, we are not saying that treatment is not important. We are not saying that, oh, doctors, you are less important. It's the prevention people, it's the community hospital and all. No, right? I think it is going to be more important than ever when you realize that your treatment efficacy is going to be not just cost effective, but actually efficacious. And once we have that mindset, a lot of things then fall in place, right? In the same way, with this spirit of a multidisciplinary approach that, of course, I'm going to share with you, please recognize that social behavioral sciences is not a good to have, right? Because I think those are the experts, the issues that we're going to bring together so that when it comes before your table, not your table, but when it comes before your clinic or your operating theater, you will realize that it facilitates your work very much, not just the process, but the actual outcome. Okay, so what I'm going to do today in a relatively short time that I have is to share with you, this is just an overview. I'm going to talk about the social behavioral change issues, right? Because as I said, we have a diverse audience, so let's agree and understand some of these issues and context, which actually P.S. Lai had laid a very good context for us. I'll just reiterate some of them. Then I'm going to do something quite different. I think most of you would not have heard of this, although I made mention about this in 10, 15 years ago in health conferences in Singapore. I'm going to talk about what does it really mean when we take a people-centric approach, which we must, in our health transformation. I like to use the word health transformation, not healthcare, because health is broader than healthcare, okay? And in doing so, I will speak about some assumptions and analysis and actions I think that Singapore is doing, as well as how we can do it even better, right? And I hope I will have some time to talk a little bit about behavioral economics, which I want to warn my people, my colleagues and others, some of them are probably my former students, don't be too carried away with the behavioral economics approach. It is important, there are places for it. The way it is being practiced in the past 10, 20 years is good, but be careful of how we practice it, right? Because there are some potential dangers, right, if you don't do it well or if you do it in isolation. I for the past 20, 30 years, I've been quite involved in various capacity with the public service, so I know how the behavioral economics approach came about and how it developed and where it might be going, right? So I want to share that with you. Because I have in the audience here leaders who will have impact on what you do as you make your decisions when you listen to your domain experts within your ministry or your agencies about behavioral economics. Then I'm going to, because this is not a workshop, right, so all I can do is to give you some examples in a non-technical way, I hope, on the various concepts and examples and guiding principles that we know from social behavioral sciences that can actually apply right in our health transformation. And I will have to just leave it to you to follow up, if you're more interested, to either approach the organizing committee or me, get additional references if you're interested in a particular topic or concept, right? So I can't go into detail, right? And this is not a class lecture, so I obviously can't give you lots of statistics or any statistics, so you have to kind of like trust me when I say that. The research has shown that, so please trust me, okay? Now, the health in Singapore, most speeches, and they are right to do so, that we hear, right, not today only, but for over the past 5 years at least, you'll find that we want to reassure our community, not just publicly outside external, but even within ourselves that, and I think to our members of public as well, that actually we have a success story and we have a very, very strong foundation, not just compared to other countries, but in absolute terms to start with. Now, think about our health outcome. PS Lai has also mentioned that, right? We have very high life expectancies, in 83, 84, 85, depending how you calculate the average. And we have actually quite high health-adjusted life expectancy. That's like the first one is like your lifespan, right? The second one is your health span. Our health span is actually quite high. But lifespan minus health span is 10 years, right? According to the current data, depending how you define health span, there are various ways to adjust for disability and all. But I think it is quite accurate to say that the last 10 years of our lives, actually on average, and even not on average, but if you look at the variance, we have quite a lot of difficult times going through, right? Obviously, for society and the healthcare, right, it costs a lot of great costs, COSTS, right? Because it is expensive, right, to ensure that a person continue to live and live reasonably and all. And it is a huge toll on the individual, the patient, or rather just the individual in his or her last 10 years, and also on the families, the communities, the workplace and all. So it doesn't matter which political perspective you come from. I think when you look at it at multiple levels, from the individual, family, workplace, productivity, community, whether it's social, economic, or medical, it makes perfect sense that we have to do something very urgently, right? Given that we are the gap between lifespan and health span is 10 years, right? How far can we move, right? We don't know. I would argue that medically, biologically, we are not going to live eternally. Your lifespan might increase, but the rate of increase is quite limited, not just by technology, but just by biology. Right? So as far as we can tell in the history of the evolution, you are not going to increase 5 years of your lifespan in our lifetime, no matter how young you are now. But how much can we change in our health span? I want to warn everybody, caution everybody, that the health span is extremely malleable. But if we do nothing, I would argue that your health span will decrease. Come again, We always talk about increasing the health span, but if we do nothing today, I think our health span will decrease. Right? But if we do something and do it well, the health span maybe can increase quite significantly and substantially. So health span is much more malleable than lifespan. This is the point which I think not many people have talked about, right? We always talk about lifespan, health span. In the past 5-10 years, most conferences I attend or I spoke, we talk about narrowing the gap, which is very important. But I don't think we realize that, or we explicitly say that lifespan is harder to change. Health span is extremely malleable in both directions, right? So Minister Ong also talked about squeezing the gap, right? I think that should be the starting point. Because of time, I'm going to go through relatively fast now. Now that you got used to my speech and accent and my speed, I'm going to speak a bit faster. Now we have, of course, low infant mortality rate relatively on United Nations. If you look at all the various measures, the development indicators, we are pretty good. Our quality of healthcare system, I'm relatively exposed to things happening in different countries due to my nature of job and work experiences. We actually have an excellent healthcare system, right? I think by all measures of quality. The usual measure we want to remind ourselves, and I think the medical profession, is that your reduction in hospital readmission is doing quite well in the recent years. And that is quite a good objective indicator that people who are discharged are not coming back as fast. You get the idea, right? The readmission rate. The analogy is in prison. In prison, when you release people, you don't want them to come back. In prison, that is the KPI that is very important. KOI, key outcome indicator. KPI is a bit different from KOI, we all know. Now, another set of, let's talk about, but I think strong foundations that we have is actually we have very good resources in capacity building in healthcare, right? I won't go through in detail because I think you're more familiar than me, but think about what we have done in the past 5 to 10 years especially, right? Even right at the time where PS were DS, right, in MOH, I think we had a very good change, transformation in our primary, acute, and long-term care. Right? So the capabilities of the system actually has increased tremendously. Technological advances is quite amazing, especially in the last few years. Even in the last 2-3 years, right? You all know about the either you pronounce it synapse or synapse, the recent rebranding, right, of our national health tech agencies. So we can look forward to exponential changes in technology, right, with generative AI and things like that. I think it's going to be very interesting. There'll be issues to deal with, right? If I can look at my face through the phone, and then you can send me diagnosis, and I can make decisions. There are other issues that we have to deal with. Imagine, right? If I told you you have HIV, of course, suddenly you have to make sure there's somebody to deal with. So when I see even on my phone, and then I stand to you and have a message to say that I'm this, I'm that, I'm hypertension or whatever. What if I'm more other things, right? So those are the issues I think we got to quickly work on so that our advances in our technology will not go so fast. It has to go fast, but our social behavioral things and medical people must catch up. Our workforce, I think, is pretty good. I'm referring to the medical workforce, not the public workforce, right? In terms of education and training, that one you all know better than me. Most, I'm involved, I know something about employee health in the public service, employee health survey, where we look at what is good. And training and development is always the dimension that I think most public officers find that you need to improve. Right? I think it's actually relatively good in healthcare, something that we need to do well. Of course, social politically, what is important is the public must continue to find your healthcare accessible and affordable. Accessible, I think, if it's not physical accessibility alone, right, that's urban planning, but also financial accessibility and therefore affordability. And that's going to be tougher. I think it's real when we talk about social expenditure going up, therefore you need to increase GST and so on, but you can't just forever increase GST, right? So how are we going to cut the cost? Not cut costs to make everybody work harder, right, but to make it more efficacious. I think that's the challenge before us. So again, PS mentioned and others would have mentioned that aging population. Imagine in 2030, right, 1 in 4 of us above 65. Now, of course, academics hate the 65 thing as the yardstick because we always want to say, especially when the academic herself is approaching 65, right? We want to say that no, right? It doesn't mean beyond 65 you are not productive. So please don't use the old divided by young as the indicator. I also wrote about things like that, about elderly should be seen as asset and not liability. But the reality is that as we biologically get older, it's going to be tougher. Your bone is going to be more brittle. It's going to be harder in terms of recovery, right? So we want to also be real that yes, there will be active aging, but older people are asset. But as we age, as I myself experience, right, I will have more problems with my knee and other things, and those are issues that we have to deal with. And of course, your chronic disease. I was with the ministers on the national task force for diabetes, right, with the Director General and all, and it is a challenge when you look at diabetes and other things. So the chronic disease part is something that I think we have to deal with, right? Many of us have hypertension. People like at my age, right? All my friends, almost all of us are on medicine, or sometimes, and those are issues that are not easy. So in short, we have a very good success story. I think strong foundations. But they are going to be evolving economic, social, demographic, political context, right? So I alluded to economic and social, economic and demographic, but actually it's much more complicated than that. And perhaps with that, I want you to understand that when we say that, I just put the white paper Healthier SG there, but health transformation began well before Healthier SG. So for the public, maybe it's around Healthier SG time, right? Structurally, you felt it, but health transformation in Singapore certainly began well before that. And what is the context and challenges, I think, facing us? Then I'll enter into how that relate to social behavioral sciences issue. This is the way I define it. I didn't lift it up, but I think it's as good as lifting it up, because when I put this definition down, and I felt that, hey, actually the white paper and everybody say about the same thing, right? I see health transformation, or many of us agree with this definition that I put up, I think, right, that we need to don't care, but we need to go beyond illness treatment to focus on prevention and have a delay our onset of ill health, so that your health span increase and the gap between lifespan and health span decreases, and to improve our chronic care, right? Chronic care, that is for chronic, especially during your last 10 years, how to manage pain and things like that. And then more in general, to enhance health promotion. Yeah? So the word prevention, promotion for academic are quite particular. When you focus on prevention, promotion tend to be seen as two separate things. So when we say focus on prevention, I just want to emphasize that I think, and I'm sure actually, that the government is not talking about prevention, promotion in the academic sense. You are preventing, not just trying to think about all the negative things and make sure it doesn't happen. You are promoting at the same time. So Health Promotion Board, you are still very relevant. We are trying to be aspirational and not just preventing bad things. We want to aspire to good things. So understand, focus on prevention in that sense, not just prevention of negative things, prevent, but there is an aspirational aspect to it. So let's go through very quickly the health transformation, some buzzword or themes, right? Healthier SG, we all know, you are very familiar. I look at it as it's basically a strategic focus, right, on what are the focus areas that we need to pay attention to. But it's much more than that, right? You look at the white paper, I think it also provides us a guide, a blueprint guide for implementation. So when we have disagreements, especially at the boardroom, in the leadership level in your agency, it is good sometimes to think back and say, okay, very easy in a Healthier SG document, what we are talking and debating actually talk about this strategic area and this focus, right? So I think the Healthier SG is not a Bible, but at the same time, it is a good guide for implementation as we, argue. Sometimes we go too operational, we forget what are the strategic goals, and I think the Healthier SG provides us that. We, of course, hear about population health, and we have population health surveys, and I've seen some of them. Very important, but I think the challenge facing us is that we can have broad indicators of our population. What is a bit harder but must do is the population segmentation approaches. How do we actually segment our population? Right now, most of us, especially of your medical training, will say segment population easy. What? Just take the census, divide them by age, income, gender, if you want, then education. Those are important. Demographics is a variable that you can segment the population, but our population do not come in separate demographics. So David is not just Chinese, right? David is Chinese, he's 59 years old, he's from a particular sector in a profession, he lives a particular lifestyle and so on. So when you put David as a Chinese, but David is not so young, right? I'm supposed to be a young senior by definition now, right? But I'm also in a particular profession and have a particular lifestyle. How do you then, do you just do a cross-step? Most of us don't, right? When we segment, let's be honest, right? When you analyze the data, you go singular demographic and you talk about it separately. But David has to be grouped somewhere. Where is David grouping? If by race he's there, but by demographic he's there, by socio-economic class, by population, where is David? You cannot have a segmented approach where you cannot find David, you see, because you are going to make policy and decide where David falls within your policy. So your population segmentation approach is not something very simple, right? It is something that you need to decide how to segment. Another way to talk about segmentation is that it's not just demographics you are segmenting, right? What about life events, people who say get divorced, right, on a particular stage, people who will change jobs when you're in your mid-40s, right, people who have to now become sandwich generations. So those are not simple things you can just lift up from your census, and those are the issues facing us when we move, which we must into a population segmented approach, right, as we interpret, analyze our population health surveys and do other things. Of course, I think this morning we have alluded to this healthy precincts as well. I won't go into detail. Some of you are actively involved in this. It's a very community approach, not community hospital, but community-based approach, right? Where I think you work with many, many people, right? Including whether it's CDC, experts, politicians, medical people, hospitals, and all. where you actually look at a geographic context of precinct and enter into a very specific deep dive into the environment and understand the issues there. It's like a part of Singapore, a mini Singapore. When you look at it, you try to really engage the people and co-create solutions. Right? I think this, with the different agencies, communities, actually is a fantastic approach. It is very intensive. It is very difficult to do. Right? I've been involved with Minister Maliki and others where we try to do deep dive engaging things. It is really very tough, but I'm very glad that you are doing this because that is, I think, a way where you can discover things that you can't at a very broad, general population level. Finally, this social prescribing thing. Actually, very frank, when I first heard social prescribing, I wasn't happy. Because prescribing in a medical sense tend to be prescribed medicine. Right? When we say social prescribing, my very first reaction when I first heard the word was like, oh no, you're going to take a medical model approach to something that is beyond just medical. Right? You know, as in the Asian context, research has shown that unlike in the West, when we go to a doctor, we as members of public, we expect solutions. I pay for it, so I expect you to tell me if I take one drug, what must I do? You basically prescribe to me. You don't just encourage me. You don't give me option. Right? If you give me option and I choose, I get very upset, for the Asian population. Whereas in the West, it's different, right? You just talk to the doctor gives you unconditional love, and then you are okay, So here, unconditional love, you are like, oh, jalat lah, KPI should gone. So cannot, right? Must give solution. And I think the prescription, the cultural context is still there. So at first, when I first heard it, I didn't like it. But when I read up more, I realized that, okay, not too bad. If you can still change the word, I'd rather you change the word. But it's okay, so I add in for you. Don't change prescribe, but call it social prescribing and health behaviors. Right? So to make it broader, and it is not just so simple that I go to the doctor prescribe me how many kilometers I must walk per day, and I must stop eating what food. It is about how do I develop individual health plans, how do I have healthy lifestyles, and how to check on me and so on. When I go to my SMU clinic doctor, I will always tell, I will tell him, say, so how must I walk? Do I exercise? Then he look at me, David, I walk 30 minutes can already. I don't know whether that's good advice or not, whether he's in the audience now or not, but that is the kinds of things. Ultimately, I still have to make the decisions, right? Then when I go back to him a bit paiseh, did I really walk my 30 minutes? That relationship becomes very important. And that's why assigning a doctor to me as an individual, right, having a long-term relationship of trust is going to affect your social prescribing efficacy and your health behaviors, which I'll talk a little bit about. Hopefully I have time. I'll speed up a little bit again. Now, if you look at our healthcare transformation, when PS mentioned whole of society, right, what I think underneath that actually is really an ecological approach as well, right? It is not just about whole of society in the sense of different agencies. I think she and our leaders are reminding us that we need to understand also how the healthcare issue that you are very focused on or focused in actually links to the more general other issues developing in Singapore, right, as it relates to community, quality of life, and so on. Now, a few buzzwords that I always use, these are from me. Think about various, for acronym, I make it simple for you by alphabetical. Think about the technological advances and asymmetries that we are facing, right? Technology is going very fast. My students know about generative AI, I think some of them more than me. Right? And I'm not an uninformed person. Right? I do read up. In fact, I do research on computational social sciences. But on some generative AI, I was quite shocked that, actually they know so much. Right? So the technological advances as well as asymmetries between groups of people, knowledge of that technological advances is not just between older and younger or even socio-economic class. Right? So be a bit careful as we roll out, especially our National Healthcare Agency, understand the broader issues and development. Right? How do we ensure these asymmetries, even if it exists, how can we deal with it better? Population composition and changes is important. We always talk about older, elderly aging, which is important. But you know that when you go out of this room as you're on your way back, if I throw a ball and the ball falls on one of the person walking, right, actually 6 out of 10 times it will fall on the Singaporean, right? 1 out of 10 it will fall on a PR, and 3 out of 10 it will fall on a foreigner, non-resident person working and living here, right? Because that's the population composition of Singapore. So you cannot have a healthcare transformation that focuses only on Singaporeans, right? You must focus on the other 4 because they are part of our economy, society, and if I have a very unhealthy foreigner here, I also have to deal with that. Okay, so be careful. Politically, it's not easy. Certain things are only accessible, for example, to locals. But the healthcare transformation and health transformation is also about the entire population. And that is not going to change that much, I think, in the proportion of our composition, but understand where the profile of the composition will provide us better. So we have advances, asymmetries, C&C, composition and changes. Now I have I and I, which is your social inequalities and interdependencies. So I won't go into a sociological long lecture with you, but we all know there are social inequalities, and that became quite clear in COVID, but it was very good that we started early. HPS is aware of that. I think she was in MOE at that time, where we ensure that the people in Kids Start and the lower income people are taken care of. So it was challenging, but it wasn't that difficult and impossible to start providing laptops, computers to every person, especially lower income people, right? And that was because we were prepared, right? Before that, we actually were already trying to take care of our less advantage and so on, and not wait for COVID to happen, which would have been very difficult. And then E&E, this is not just a politician's job. I think public expectations are very important. We need to understand. That's why I remind people, don't introduce people with very good bio. Just temper it a little bit, right? Because expectations unmet is going to be terrible, right? Unmet expectations is always the root of many problems. So it's not money. Money is not the root of all evil. It is actually, because you need money, it is the unmet expectations, right? And the engagement part is important. Are we going to have a COVID-relevant thing? If it manifests itself, we'll probably react a bit differently because we are more prepared. But incident responses need not be macro, can be minor, can be just an outbreak. And our communicable diseases, people will be involved, but they cannot be the only one. So how do we as normal, say GP and so on, respond to those things, right? So again, our response to incidents and our resilience become important. And finally, and this is not a political leader or audience, right? So I'll speak quite differently on this. As leaders, I think we need to continually not just know about generative AI, but a lot of other things. Especially I say social behavioral, because you'll be bombarded with your staff telling you and consultants telling you this and that. So as leaders, we need to probably be at least have a very good grasp at the general level, not the technicalities, and able to develop that. Otherwise, there will be a divide, right, between what you think and what actually works and so on. So quickly then, if I look at health transformation, I would say that I have tried to put before you that we indeed have multiple stakeholders, there are multiple needs, and how working together becomes very important, right? It is not a political term, oh, let's work together, whole of society, right? It is important, right? And I myself, in all my work, I find that working together is the most challenging, most important, but when it works, right, it really works. And when it doesn't, it really doesn't, okay? And so it is important. And then we understand that the context that we are in are dynamic. We should adopt a life course approach. That's why you have things like Gusto and others that we start very young. So you don't wait until people are old and then you do something with it, right? Even in SMU, we have this ROSA where we look at elderly people, and I'm a collaborator, I think, on that project. And we're beginning to look at people who are younger now and so on, right? So the idea here is that underlying it, we need to have some kind of evidence-based contextualization and apply, and don't just read a textbook on social behavioral sciences, listen to somebody like David or others and just try to apply blindly, right? Understand the context and work together to problem solve. Now, I want to be very honest with you, which I can be. I'm not a civil servant. I always tend to be able to say things much more freely, right? And maybe that's why I get invited by public service a lot. I can say things that they want to say but cannot say, right? I think there are clearly tensions, let's face it. As we do our healthcare, I think we are a wonderful group together and we are going to get it work. But there will be some tension that we'll be ready to be prepared, but we can deal with it, right? There will be an issue about centralization and democracy, right? When we make certain decisions, there'll be doctors who say, why can't I have the freedom? Where are the choices, you know? But this is what we all think, right? Sometimes it's going to be very fast implementation and HQ will have a challenging task sometimes to balance between the idea of how to centralize and how to democratize decision making and so on. There will be issues about information power, right? If you share with others, you actually find that, I don't have my information power decreases. here I want to talk to experts like you and myself. Sometimes we go conferences. I don't know about medical, but it happened in social behavioral. We don't say everything, right? Because you're very scared. I say already when you publish my idea, because you can do it. So you try to it's like the Chinese food, right? You don't teach the last stroke, you teach the until stroke number 8, and then the last stroke you keep to yourself in case your disciple rebel against you. But that cannot be the situation, right? Because if you try to keep the last stroke, right, the last stroke, you will die with the last stroke, right? No pun intended, right? So the issue here really is that don't be afraid to share information, right? I other than when I sign internal security, then I can't share. But most of the time, I just share, right? Because I know I'm going to die with all these ideas in my head, and it just remain as ideas, right? So be free to share your ideas. The more you share your ideas, you think your info power decreases. No, actually it can increase, right? So the whole idea here is, I'm not going to go through with you, that don't think cohesion and diversity is antagonistic and so on, right? Many of these things are not trade-offs, zero-sum. They can actually work together. Right? Because of time, I was given a card to say, oh, you need to end soon. But after this is your break, right? So I can steal 5 minutes from you, isn't it? So I think we need to understand that our things are located within a healthcare setting. They are evolving context, and the approach that we are going to do, whether it's social behavioral or not, is going to be more pluralistic. We are going to be quite paradoxical. Things that you thought going to be opposing actually can work together. Therefore, we need to be more integrative and so on. Now, I just want to say a bit about behavioral changes and leave it as that because of time. Especially I'll talk a bit about behavioral economics, which I think is great but dangerous when we are not well informed and implement it blindly and listen to our, these are my ex-students, listening to our younger staff who may not be actually get a whole picture, and then sometimes you can implement the wrong thing. Right? So what we need, we know we are already doing this, we are going beyond some E's to include other E's. We have gone beyond economics, ergonomics, engineering, enforcement. Right? We know that health transformation, we need to go and focus on the education and engagement, which means we need to understand people's expectations, doctors' expectations, patients, and so on. Understand how to make the encounters better as they relate to each other. How are we better with evaluating programs? We have a lot of initiatives, but we don't have many program evaluation. Right? Any good scientist, practitioner will tell you, say, don't just implement, right? Evaluation don't start after the program is over. It starts while you are planning the program, right? So that's important, and how to improve the quality of the experiences. So if I were I'm not ended, but if I were to summarize this behavioral change thing, right? Really the efficacy of our behavioral change solutions, right? It's going to be highly influenced by how you approach the issue as leader or as an expert, or as just a part of a team, and to understand how we, meaning people in general, think, feel, and behave, right? And let me then say quickly about behavioral economics, because I think most of you are exposed to, when I want to change behavior, I go to behavioral economics, right? Yeah, behavioral economics is great insofar as it tells us that traditional economics is wrong, right? And good economists will know that traditional economics is wrong, that we are not homo economicus, right? But we are homo sapiens, and what that means is that we don't behave like the economic rational model dictates us to be. But I just want you to remember this slide. I think you want to use behavioral economics, you must be scientifically defensible, you must be evidence-based, you must be aware of the context. And in order to do that, I don't think you have a choice, right? You have to go beyond and maybe not use behavioral economics as a guiding principle, but behavioral sciences. Behavioral economics evolved in a very specific context on economic decision-making. The literature on behavioral economics is very narrow. I know it well. I've worked with Daniel Kahneman and others, right? So I know what it means. It came from a particular zeitgeist of the time, right? I suggest you actually stop using that word and think about behavioral sciences, so that you go beyond a very, very specific a class of advisors, right, to tap on the expertise from multiple disciplines. Right? So your behavioral sciences, social behavioral sciences, if you like, right, is going to be very critical to improve. Right? Let me quickly show you a list of things. I won't go through them, don't worry. So that for those of you who are a bit confused so far, what I say about behavioral economics can follow up and get an idea. right? So the basic idea about behavioral economics is that we don't function like the economic. When you buy your house, you don't function it like what the economic model tell you, that you do an Excel spreadsheet, and then you do a plus, minuses, and then you decide, right? So that's not the way we make decisions. Now we know that. We also know that when we do things, we don't treat sunk costs as truly sunk, right? We tend to use various strategy of systematic biases. We are very averse to loss, so we are very sensitive to negative things and not so sensitive to positive things. We procrastinate. That was the basis which you do your organ transplant, you're opting out, and so on. But we also know that then you have this behavioral economic choice architecture, and you think that, okay, so because of this, I'm going to tell my boss now that please use default option to capitalize on inertia. So health promotion board, you might then decide to say that everybody must do this, you have to opt out, and so on. Then specify your choices, how you frame incentives properly, how do you encourage people, and so on. So these are the traditional list of things you tell your boss what to do when you are a behavioral economics a guy, right? You are, of course, it's a good start, but please remember that people are rational, even though they may not be economically rational. Rationality means that when your wife wants something and you respond to your wife, you are very rational if you don't use economic rationality, right? Same for husband. When the wife responds to the husband, don't just use economic rationality, right? It's not going to work. And that doesn't mean you're not rational. You are very rational because rationality is about goals. How do I approach the goal? How do I actually not frustrate the goal, and so on. So once you understand that our doctors, our patients, our leaders are trying to achieve goal, they are monitoring their goal progress, they are trying not to frustrate the goal, then you realize that they are extremely rational of why they did what they did. Now, once you understand that, behavioral economics and application actually doesn't work, right? Because it assumes all the things we do are biases and heuristics, which sometimes true, but often it is not true. You need to understand the basis of people's decision, not as bad biases, failures in economic rationality. So I need to therefore understand what are the systematic difference across my population groups when I segment them. Now you see the linkage back to population segmentation, how they interact with their environment, and so on. Again, because of time, I'm told that time is really catching up. We therefore need to go beyond behavioral economics, right? And I won't go through this. Some of the slides I should be able to provide to some people. We need to understand the very importance of being knowledgeable about what motivates people's behavior. Why do I talk so much about behavior? It's going to drive your health outcomes. You can have the best policy, best technology, but if you don't understand why people and how they behave, right, you are going to affect your behavior. If you don't understand what is theoretically possible in people's behavior and what is practically plausible, it will also affect your outcome. It is very easy for us to sit, right, say even in the cabinet, you sit and you argue about how humans behave. If you don't have proper evidence, you are talking about theoretically possibility of humans' behavior. You must know what is the practical plausibility of the behavior that you are making an assumption of. And that's why we need to go beyond specific disciplines and understand the reality of it, right? Because as medical doctors, you know a lot about the central nervous system, but you don't know as much, and you know much more than me, but you know less than me about behavior, right? So we all got to work together, for example, when it comes to health and so on. So this is the picture, probably one of the only picture you'll see in my slides, right? People centricity really means to know how people think, feel, and behave. Therefore, you must understand the science of cognition. There is a whole science of cognition, right? There's a science of emotion. There's a science of behavior. These are published in top journals, done by top universities, and there are actual regression statistics to show that it works, right? So we are not talking in ivory towers and so on. So we must make use of this. Right? And again, I show you practically that what I've done, for example, in Singapore, I always advocate the Wings model. I've mentioned this in some public writings. Internally, when DPM Gunn, when he was then health minister, we had a ministerial conference. I represented Singapore and I presented this Wings model. I applied it in environment as well. Right? So just have a simple checklist, understand that people's values, and which differ across population segment, understand that we have a private and public image of ourselves. Do you want to look good? Do you want to be healthy? And things like that are important. There are norms of how we should behave, and that's issue about convenience. You want to make a recommendation that's convenient so that people will actually do it. So your health plan cannot be extremely inconvenient, for example. There will be times where we have to do enforcement, right? We actually have enforcement now on the labels about drinks, about sugar content, and so on. right? Because of time, if you like, you can just take one of the 60 newspaper articles that I've written on what does it mean when I apply this in COVID, for example. Then you get a bit more understanding about the meaning of the Wings model, right? So I'll skip this part. No, I won't skip this part. It's the last two slides that I'm going to show you, right? So you don't have to show me the time anymore. I'm ending. The examples in behavioral sciences, let me go through very quickly the list for you. I won't go through every one. As I said, I can share these slides with you. I think it's okay. Please understand there is a psychology of intended and unintended consequences. I think many of us know about unintended negative consequences, right? That's why you have scenario planning, you know, your PMO, you have risk horizon scanning and so on. But actually there's positive multiplier which are unintended. You were doing something to do a policy goal, right? You make a decision, then you realize that, hey, you didn't know that when you do that, a lot of other positive things happen without you realizing they are wonderful, serendipitous, positive. So don't be too pessimistic, right? Understand that there will be unintended consequences that can be negative and positive. So let's read up a little bit about how that happens, what to do when it happens, and so on. As I've said, right, then when you approach goals, you don't have to be so trade-off. There's a whole psychology of paradoxical thinking about how to think in a way that go beyond just zero-sum trade-off. Singapore has relied very heavily on zero-sum trade-off, right? You cannot have your lunch and eat it, you know, have your cake and eat it kind of approach, which is correct in the earlier days. But today we find that there are many things that we thought with zero-sum trade-offs actually can be paradoxically not really opposing, they can be achieved at the same time, right? And to do that requires us to learn to take a perspective of the people who are very different from us, right? That's why we put our leaders everywhere now. You put our leaders so that they can see different perspectives, right? I can't help it if you are not you can't help it if you grow up in a very rich family, but I can actually make sure that you work with people who are not as rich as you, then you can understand their perspectives, okay? So just because you grew up in a rich family, it doesn't mean you can't empathize. Please take note, right? And that's why this criticism of elitism sometimes get a bit out of hand. You can be very poor, then you become rich, and then you can be totally an idiot, you know. So it doesn't mean that, oh, I'm poor, I'm great, I'm rich, I'm no good. By the way, I'm poor, so just I was poor, just to put it in perspective. Now, understand the psychology of trust. I just want to spend a little bit of time, please allow me, right? Trust is going to be critical. If you don't trust your leaders when they make these fast, rapid changes, we're all going to be in trouble. And doctors, nurses, please understand, and my paramedical people, your patient must trust you, right? And that's why I thought it's a very good idea to put the same doctor as much as you can with the patient, right? Because trust takes time to develop. It's very fragile. It's very easy to break. It's very easy to erode, very hard to repair. But there is a whole psychology of trust, right? I've written tons and tons on this. We have actual research on this. So please learn a little bit more about trust. There are different dimensions of trust, for example. How do you repair trust? How do you prevent it from eroding and so on? Give me a bit of time. I want to mention subjective well-being because well-being is very important, right? There will be things about cognitive satisfaction, emotional feelings of positive effect and minus negative effect. But there's also a topic that I've done quite a bit on. By the way, I have a official YouTube channel that SMU that you can go there and sell Koyo a bit. You can go in there and there are different public lectures that I have put up. There's one on meaning in life that I did recently, right? Meaning in life actually affects health transformation, you know. Because if I can have positive meaning in life through my community networks, through the way I engage in my work, actually my mental health my mental health is going to increase tremendously. I'll be much more resilient, right? But then there are dangers about if you're not careful with how you deal with meaning in life and you give the wrong advice. I always tell my students, meaning in life is very important, but please don't give the wrong advice. If a person has cancer, see a doctor. Don't tell the person, don't worry, life is meaningful, right? You need both, but don't give the wrong advice, okay? I won't have time to go through some of this a little bit more technical thing, right? Just understand that people make comparisons. Fairness will be very important when you do health transformation. People will have a strong negativity bias in the way they approach things. Whatever you do new, the first reaction is going to be negative. Please understand that, because people will think, what if this, what if that? No, people are quite resistant to change, including me and including your leaders, right? So we do have a strong negativity bias that we need to be aware of. Those of you with secretaries, I give this example, apologize to secretaries first, all the time, right? If you scold your secretary once today, then after you praise her once, him or her once, he's not zero against you in his valence against you, right? He or she is negative, because +1 and -1 is not zero. Mathematically it is, psychologically it's not. The person dislike you rather than like you, right? And I find that actually I have to praise my secretary 27 times when I scolded her once, okay? So it is very important that you be sensitive to this negativity bias, right? It happens to all of us, and we have to deal with it, right? I really need to stop because of time, and I apologize for that. I can give you this list of things that you can go on and on. I would just want to, as you clearly know that I have not given you actual knowledge or technical stuff, right? But I've given you a flavor that it's not about behavioral economics per se. Social behavioral sciences is very wide. It's about things that you thought you know, but you might not know, or you might know it wrongly. So please, just like I wouldn't think that I know the central nervous system without talking to medical people, don't just assume that your assumption of behaviors are correct. Let's look at the evidence and data and talk to good, relevant experts and so on. I would strongly advocate that you apply the Wings model, very simple, without knowing anything. Consider the consequences in the decisions that we make, right? Be a bit more pluralistic and paradoxical, and don't look at things as trade-offs and stop there. Therefore, your integrative and whole of society approach can really work. Learn to see things from people's different perspectives, and then you build and maintain trust, which is going to be critical in your health transformation efforts, right? And then increase our well-being through other ways. Of course, in doing so, I didn't go through one of the slides, so this might be a bit harder to understand, right? Understand the basic important concepts with so much evidence. Please don't go and do another survey and another research grant on these concepts, right? There are so much data on this, including in Singapore, not just by me, but by others. We have enough data to give evidence-based contextualization advice on social behavioral sciences. Do it for population and things that are very innovative, right? But don't go and give another research grant on doing something that actually we have a lot of evidence on, right? And that's the things that we need to do. Okay, for the guys lifting up the card, I am happy to tell you this is the last slide, that when we approach transformation in 2015, I used the term expire, and this is what I want to end with, right? I think as we aspire to do better, to prevent bad things and promote good things in health, we are going to have to learn to be adaptive, all of us. There is a psychology of adaptability anyway. We have to be more strategic, and the Healthier SG paper, I thought, white paper is a good start. We have to be quite principled in the way we approach. There will be pragmatic decisions to make, but must have a set of clear principles that all of us agree on. Have to be integrative and get everybody on board. Make sure the science, the research grant that you fund, don't just fund because they say it's multidisciplinary, but because it is relevant to the solutions at hand. And to do that, we need to be evidence-based. By evidence-based means you need to look at good people, good science, including the science of behavior and so on. Okay, if you want to read some more, you can go and read all the books that I've written. They are not scientific books, they are practical, evidence-based books. These are not just books, these are books by me, but some of them are edited by me. So there are other people who wrote chapters in the book that I edited. So you're not just reading one perspective from David. I think there are 12 books here. You can, if you type David Chan notable titles in Google, I think this same thing will come up, because that's what I did 2 nights ago. Okay, and this is what the publisher put together. Right, so I just want to thank you, and if you have questions, which I'm sure you have, you should have, please wait until the panel session. After all the 3 panelists have spoken, I'll be glad to have 1/4 of the time out of 4 of us to answer any questions that you might have. Right, thank you very much.